Yes, this is Ted Dietrich. I was very impressed by the concept you have there. I was wondering why you would have chronic aneurysms in the hospital in the ICU. Are they waiting for treatment? Are you working them up? Is that how the concept works?
Disconnected.
Dr. Mehrotra, can you hear us? I think we lost the connection, audio connection.
Huh? No, I can't hear. There's no connection. Hi, Dr. Shetty. That was a good lecture. I could hear it. Good. Yeah, we're showing one patient where we have a large thoracic aneurysm, and what we're doing is we're putting a chimney into the left subclavian. So chimney is what, Dr. Shetty, here I'll show you. You can come this side, Dr. Shetty. So we have a access from the, we have an access from the left-hand brachial, and this is a covered stent, which we put with the stent graft. So that lies by the side of the stent graft, and you can actually bring the origin of the left subclavian proximal so that it continues to perfuse, because there is a big vertebral artery there. So we didn't want to sacrifice that. So this is the first time we're demonstrating chimney in a case. So I think they're just live. We got disconnected after this.
Dr. Mehrotra, could you hear us?
Hello? Yeah, Dr. Khanna?
Okay, we can
Can
hear
you hear
you. Dr. Dietrich and Dr. Buckley had some questions with Dr. Devi Shetty. Is he around?
But I don't think he has a mic on his head. You want, should we just ask him to connect, and they want to, Dr. Shetty? Dr. Shetty? They want to, Dr. Dietrich, he's a vascular, endovascular specialist from US. They wanted to talk to you. You have a headphone connection for him? Keep the mic. Yeah, just 1 second, Dr. Khanna, he's coming.
Okay.
We enjoyed his talk very much.
Hello? Dr. Shetty speaking.
Yes, we can hear you now. I'd first of all, congratulations on that very nice work. I was interested in your size of your intensive care unit. You said you had a lot of chronic aneurysms. Those are post-operative patients, or are they patients being worked up for one of these procedures?
No, most of them are pre-op patients. Yeah, most of them are post-op patients, especially if they develop renal failure on dialysis. They take a long time to recover.
Yes, I thought your assessment of what it takes to build that kind of a center was very, very accurate. We have the same expenditure problems in the United States. Those cases are certainly not ones that you will generate a large return for your investment on.
Yes, the aneurysm surgery, I guess in the long term, will give good returns. But when you are building a large experience, it's a money-losing game. But then someone has to do it.
Absolutely right. Someone has to do it. And in the end, that's, for the patients, that's what we have to do.
Exactly.
Thank you very much, Dr. Shetty. Now, I think we should go on with the endovascular case. Dr. Sanjay Malhotra, we can see that you've got your device in and you're ready to deploy after explaining what you're going to do. Probably you also have a chimney placed already. You just have to release and start the procedure.
Sanjay, this is Ashok Seth speaking. Did not...
Yes, Dr. Seth, how are you?
Great, very well, thank you. Did not see your aortograms very clearly to start off, so we really have to start off right from the case itself.
Right. So let's show the aortogram first. Can you show the insert the aortogram, the picture which comes there? Can you show it there? No, I want the picture to be shown. Is it visible to you? Yeah. Now freeze that there. Freeze that there. Freeze it. So freeze it here. So I'll just explain you what we have. This is a gentleman who has a large thoracic aneurysm just after the left subclavian artery, and you have a little kind of a leak inside that. You see the aorta is actually not very enlarged, but the maximum size of the aneurysm, which I think you can see a little sill out of that outside, which is calcified, about 7.5 centimeters. Just below that, you have another aneurysm. Can you show the next shot now? So run that. You can see the sill out of the aneurysm, which is leaking. And show the next one again. And no, the previous one, Run that, yeah. So you see one more aneurysm which is below that aneurysm, and this is what we wanted to cover with one device, but it is falling short. So
what we have is a dissection proximally, just beyond the subclavian, and an aneurysm subsequently.
That dissection actually is a very localized dissection. It is not traveled anywhere. So I feel it is just a kind of aneurysm with dissection. And the second aneurysm is again kind of a secular bulge.
Sure.
We need
both
to cut that
pathologies
also.
coexist. Yeah.
Yes. So what we thought that we will, and this patient has a very large left vertebral artery, which appears to be a dominant artery as compared to the right one. And we didn't want to sacrifice the left vertebral. So what we thought that we will do a chimney here. So what we have done is that initially we have thought that we will cover with one endovascular stent graft, 200 millimeter, but that was not sufficient. And so now, can you show insert the angiogram also? Show both the images. Can you show both the images? So what we thought that we will put one device below and one device above. Now this is a 40, the proximal part of the device has to be 40 millimeter. And the second device is 36. So I have deployed the first device as the lower device so that we can telescope a larger device and a smaller device from below upward. So the first implantation was done of the smaller device. Can you show next images, please? Next images. Go show the angiogram. Don't show me. I don't want to be shown. Yeah. So this is the first device opened up. And now we have taken the second device and we are positioning it just close to the left carotid. So now we can just keep showing the angiogram. Don't need to show me right now. If you want, you can show the inset of what I'm doing here. So now we are just pushing the device a little more and we'll take a shot there. So you're ready with pigtail injection? Push it, please. Connect. Raju, connect. Yeah, connect. Suck. Yeah, no bubbles. Okay, show me the arch a little better. So you come down, table towards you. Pull the wire a little in. So we'll take a picture there. You're ready for the picture? Lungs off, please. Inject. So I think that looks okay right now for me to position that. I would need to see where would my chimney be, and chimney of course I can move later on. So I would deliver the proximal end of my endovascular stent graft now Can you mark that, please, on the monitor? And I'm just trying to open this device now. I'll just go a little more forward. I can always pull it back later. Just leave that, please. Now just keep that open a little. So this is, I'm unscrewing the stent graft now, and you can see it opening. I'm still much forward, so once the proximal part opens up, I'll stop and I'll run that shot again, please. So I have not moved the table, so my imaging will remain the same. Stop that and mark it left carotid now. Left carotid. Okay? No, Raju, that's the point, that's the point, that's the point. Okay, now I want them to pace the patient, and we'll take one more shot, please. We'll take one more pigtail shot. This is a very important part of our deployment. So pace the patient now. Sorry, 1 second. We'll take a shot. You're ready for injection? Lungs off. Inject. So we may have to come back a little bit. And I will have to push my chimney a little down. That's the place I will leave it. Okay. Now I want one more shot, Raju. Okay, lungs off, don't move it. Inject. So that looks okay to me. Now pace the patient. Pace the patient. What's the pressure? Tell me the pressure. Yeah, pacing off. Okay, we'll take a shot now with the pigtail. So we have delivered this device. Can I have the pigtail connection again? And I'll take the pigtail out now from the side. Can I have the wire? Any wire, a Terumo wire is better. So I'm putting a wire inside the pigtail to take it out. Just show me the lower end of the stent graft, please. Lower end of the stent graft. Unlock the table. Yeah, it's delivered. Yeah. Leave it. So chimney is still not delivered. We will deliver the chimney after we have seen our position is okay. And we will have to dilate the chimney along with the stent graft balloon dilatation simultaneously. So I'm going back into the stent graft now. Show down, please. Show down. Can you give me a stiffer wire? It's not going there. No, it's gone, it's okay. So just show the pigtail now. We'll take a shot here. Connect again. Push to contrast. Suck it. Sucking. Yeah, okay. So show the arch of the aorta first. Table towards you. Okay. Now, lungs off, please. Inject. So our left carotid is fine. We have not dilated the stent graft, so I will take the balloon onto the stent graft. And do you think my position of the chimney is okay? Or should I push it a little forward?
You've been very accurate.
Okay, so I think
very precise.
I might have to push my chimney a little forward. And I'm going to take the sheath out of that. I can always pull the chimney back a little bit. So this is the sheath out now. And I will pull my stent graft back. Stent deploy the sheet back, Rajesh, we will have to take it out now, and a balloon, keep the balloon, prepare the balloon now. So we just hold it, sister, here. So I'm going to pull this, keep feeding the wire. Yeah, fill it. You want to connect it? Okay, load. And do the loading. You disconnect and put the other one. Okay, you're ready?
Malhotra,
Take the stent graft out. Yes, that's
you take that out, and then I want to ask you, what was your indication for the chimney in this subclavian coverage?
The vertebral is extremely huge on the left side as compared to the right one, and I was a little concerned. And this patient's son-in-law is a doctor, and he was extremely worried about that what will happen to the subclavian. I told him nothing happens.
Yep.
When he talked about strokes and other things, I said,
and his carotids are fine,
yes,
aren't
that's
they?
safe.
Both his
Carotids are
carotids and
fine,
vertebrals
yeah.
are, and the right vertebral is fine.
Right vertebral is small.
Right vertebral is small.
Yeah, that's the concern we have. Right vertebral is very, very small. So I will take my final picture, take the balloon. And I need to inflate the chimney also now. So we need to prepare the chimney. A 20 cc syringe. 20 cc syringe with contrast. Dr. Seth, I was also not very keen to actually go ahead and do that, but then that left vertebral always put some doubt. We never worry about it. I have never worried about it.
Correct.
I have had one stroke so far, but then somebody talks about something and then you say, okay, you can't give a guarantee it will not happen. So I said, okay, we'll put a chimney. The deflator, please.
Dr. Malhotra, you have 4 minutes. So I think
Yeah, I'm just finishing. Deflator.
Yeah, you're almost done.
Okay.
Did you also do a prophylactic
Yes, stop.
spinal cord, spinal fluid drainage?
No, I didn't do that. Balloon, put it in this one.
So in your
The balloon.
practice, if you cover such long lengths of thoracic aorta, do you never do it or you do it sometimes?
I think I'm reaching only up to T10. I'm not actually even going closer to the, I will still do a pigtail injection now. I am not very close to the L1, T12 junction, the artery of Adamco-Vicks or the spinal artery. So I think I'm okay there. Okay, we'll go. So that's my balloon there, and I want to take a pigtail shot now. Okay, push. Connect. Suck. I want to see the left vertebral also. So just table towards you a little bit, please. And lungs off now. Raju, ready? 1 second. Ready? I'm just waiting for the injector to get ready. Okay, lungs off. Okay, inject. So I'm far from the vertebral, and the chimney is nicely positioned. So I'll go up on the chimney now, and you go on the balloon. Go on the balloon. 1 second. We need more contrast.
So what stent have you got there for the chimney?
That's an atrium 959. You go ahead on this. You go. Yeah. Wait. Pace the patient, please. Start pacing. Yeah, pace.
Want to see fluoro?
Yeah, go. More. Down. Keep pacing on. Okay. Keep pacing. Negative. Full negative. I'm also negative. Can I have it 50 cc syringe, please? Facing off. 50 cc syringe. Yeah, 1 second. Record that, please. Slow record. That stent graft, the atrium takes a little more time to deflate. But I think I'm okay. Oh.
So is that a Reliant balloon or it's a trifoil balloon?
It's a Reliant balloon. Okay, that looks all right. I have to just take it out now. That's negative, so I'm going to pull it back now. Okay, just see if we can pull out a little bit. That's it. So we'll take a pigtail shot again now. Ready? I want to do one more balloon dilatation. There. Okay, let me go.
So
Balloon.
we have less than a minute left, but we are still watching you. We may delink any time, but it's very interesting. We want to see the final result.
Okay, start pacing. Okay, stop pacing. 1 second. Keep pacing, keep pacing. That's a calcified aorta because that place is very hard. It's not opening. See, the stent graft is not open up much. But I'll just show you a shot. Let's see how we think because we may disconnect. So just take a pigtail shot to show you how the chimney looks. Okay? You ready? Lungs off. Inject. Still there is a leak. I would probably do a dilatation there, but the chimney is working well. I may have to do a dilatation close to the chimney. But stent positioning is okay. There's a very tiny leak there. I'm not very much worried about it because it's not a big aneurysm. It's already thrombosed. And I think I'll be okay. So, but if I have time, I'm just going to do these dilatation one more time. Okay, start pacing when I tell you. I'll just do it there. I don't want to do it against the chimney. Okay, pace the patient. Okay, show me the pressure. Okay, keep pacing, keep pacing. I always do it under pacing. I think the reason I can precisely deliver on stop pacing is because of the pacing. Otherwise, the stent graft always moves. And I have, thankfully, thank to God, I've never had any migration so far. Maybe one, and I have to extend it. I will not do it much there, just a little bit. Okay, and I will do the overlap segment now. And I'm going to show you one more injection if we have time. Okay, come there, show it please. Move the table up. Pace it, start pacing. Okay. Store that image, stop pacing. I pace it only when I feel I'm just going to occlude it, and I stop as soon as I feel that I've actually done enough. I just do one dilatation there. Okay, start pacing. Keep pacing, and stop pacing. I will just do one more shot and see if you can see that aneurysm sealed off at the proximal end, but I'm not very much worried about it. Show me the arch now. The last shot we'll take. Okay, show the arch. Yeah, that's it. Ready? Injection. Fluoro. Position is okay. Okay, lungs off. Inject. So that is the proximal to the distal to the chimney, so you don't see the chimney filling. Maybe I'll take one more shot later on. I show the lower part. I want to do a shot there. Okay, one more shot. Lungs off. Eject. Now that's okay. So the lower one is also covered. So, yes.
We just missed the shot.
Oh, you missed the shot?
Yeah, the previous one.
Oh, you want to see that again? I'll probably do one more shot. Okay, we'll go with the pigtail in and show the arch now. We'll take a shot there now. Okay, ready? One more time, last one. How much contrast so far? Okay, fine. Okay, ready? Lungs off. Inject.
Yeah,
So that looks okay. There is still a little bit of leak, which I think I would not bother too much about because it's not a big aneurysm, and I think it'll seal it off. What do you think?
Dr. Dietrich, what's your comment on this?
I think you might have, I think the distance of overlap between the end of your thoracic graft and that chimney is pretty short, and you may have a little leak along the gutter there.
Do you suggest something to be done for this?
I wouldn't be too concerned about it.
I'd
I
watch
think you've
it.
got good seal on your aneurysm and your position of your graft is good. You're heparinized, and
Yes.
I would say you've probably accomplished what you want, and then you can follow up and see if it's going to need something there later. But I don't see any acute problem.
Yeah. A lot of,
All
lot
right,
of
that's
times,
what I think.
a lot of times those close, they seal when the heparinization wears off.
Right. So I think that's about it. Thank you very much for your attention. I think I must thank Dr. Rajesh, who always does it with me, and he's
Good
been
job.
listening. Dr. Rajesh has assisted more than 150 cases with me.
Yeah.
We want to become percutaneous, but we want to lose him. We don't want to lose him as well. So thank you very much. And to the right of me, Dr. Praveen, and our sister Sangeeta, our technician Alex, Raju. They always understand now much of it better. Sometimes I get a little worked up, but they're very nice, coordinated team to do this job. And thank you very much for your attention.